I'd like to introduce Christine Hughes. She's B&I's Vice President of Institutional Advancement, who with great pleasure will introduce our presenter.
Thank you so much, Bree. And I just wanted to give a nice shout out to Bree, because without her help and the help of the team, we wouldn't be able to put these incredible webinars on. So thank you so much. For those of you who have joined us before, welcome back. And for those of you who are new, welcome. Approximately 30% of individuals who have had a stroke live with aphasia, a speech and language disorder that affects a person's ability to express themselves verbally. Aphasia may also affect language comprehension, reading, and writing skills, and it really affects their daily living. Susan Wortman-Jutt graduated from Hunter College, City University of New York, with a Master of Science in Communication, where she received a Certificate of Achievement Award. Her clinical speech language pathology internship included Lenox Hill Hospital, Jamaica Hospital, and Mount Sinai Medical Center, New York. In 2001, Susan began a clinical fellowship year at the Kessler Institute for Rehabilitation in Saddlebrook, New Jersey, and remained there as a speech language pathologist, treating both inpatients and outpatients. From 2013 through 2018, Susan collaborated with the Brain Stimulation and Robotics Laboratory at the Burke Neurological Institute under the mentorship of Dylan Edwards. During her tenure collaborating with Dr. Edwards, Susan participated in 2 clinical trials. These included a non-invasive brain stimulation study for the treatment of post-stroke aphasia in collaboration with McGill University and the Max Planck Institute, for which Susan was the evaluating clinician. Additionally, at Burke Neurological Institute, Susan was the study coordinator for an international clinical trial spanning 13 sites, which investigated a dysphagia detection device for use as a screening tool in swallowing disorders. Susan has been a speech language pathologist at the Burke Rehabilitation Hospital since 2007, where she has specialized in the treatment of speech, language, voice, and swallowing impairments due to an acquired neurological injury or disorders such as stroke, traumatic brain injury, or progressive neurological illness, among others. It is my great pleasure to work and introduce you to Susan Wortman-Jutt.
Thank you so much for that lovely introduction, and to all of you for being here today. I'm going to share my screen, if I may, and talk a little bit more about myself in just a moment. Okay. Okay, there we go. All right. So before we begin, I'd actually like to ask you all to think about something for a moment. I'd like you to think about the very last time you spoke with someone today. It might have been just a few moments ago on Zoom, or it might have been that you said goodbye to someone, or perhaps you exchanged some other type of social greeting. And I want you to think about what it would be like if you could not do that, and how that might impact your sense of independence and your sense of yourself. For about 1 million people in the United States alone, that is their reality. And that's what we're here to talk about today. We're here to talk about aphasia. The hallmark of aphasia is an inability to find words, but not just any words, to be able to find the right words to say, to the degree that it interrupts your activities of daily living or causes concern for the person's safety or quality of life. So what we're talking about here isn't just that tip of the tongue feeling that we all have sometimes, right? We all know what that's like, where you're searching for a word and you just can't think of it. We're also not just talking about a slip of the tongue where you might mean to say one word and another word comes out. Within the realm of normal human communication, we've all experienced those things from time to time. But with aphasia, we are talking about something that makes it difficult to participate in social activities, something that interferes with someone's ability to work productively. And if it's severe enough, aphasia can impact someone's ability to ask for help or make it difficult to provide important personal information. So you can imagine that aphasia can cause social isolation and depression. Aphasia is a lot more common than people realize. Now, this information on the slide here is taken from the National Institutes of Health on their website in 2016. And on that date, they found that there were 10,400 new cases of multiple sclerosis. And I think that that's a disease that most of us are at least somewhat familiar with. We've heard of MS. In that same year, there were 50,000 new cases of Parkinson's disease. And again, this is a disorder that I think most of us are fairly familiar with. In that same year, there were 180,000 new cases of aphasia. And yet, interestingly, aphasia is something that most people have never heard of. So you've heard me mention the word aphasia a few times here already. What is this thing called aphasia? Well, it's an acquired language disorder that can impact any and all aspects of communication. And that includes your ability to speak, your ability to understand the language of others, your ability to read, to write, and even to gesture meaningfully can be impacted by aphasia. Aphasia can vary by type. There are multiple types of aphasia, and it can also vary by the level of severity. And it is often, but importantly, not always, accompanied by a motor speech disorder. And motor speech disorders have to do with articulation and the sounds of speech. Those generally fall into two categories, dysarthria and apraxia of speech. But I won't be talking specifically about motor speech disorders today. The important thing is to understand that while aphasia is often associated with motor speech disorders, they often co-occur together, it is in and of itself not a motor speech disorder. It is a language impairment. So I said it was an acquired language disorder. How is aphasia acquired? Well, the most common way that aphasia is acquired is as the result of having a stroke. But aphasia can also be acquired from traumatic brain injury, from brain tumor, from various neurological diseases. Just as some examples, some of the Parkinson plus syndromes like progressive supranuclear palsy, multisystem atrophy, those are some progressive disorders that are associated with aphasia. Additionally, encephalopathies or other, that's another way of saying other kinds of trauma to the brain, injury to the brain, like illness, tumors, lack of oxygen to the brain or hypoxia, drug overdose, etc. Now, dementia is another illness that is often associated with aphasia. There are specific variants of dementia that are associated with aphasia, and those include primary progressive aphasia, itself a form of dementia, vascular dementia, and some of the atypical variants of Alzheimer's. But today I won't be really focusing on dementia or these other specific causes of aphasia. I will be specifically focusing on stroke. However, I do want to say that if anyone has any questions at the end of the talk that relate to some of these other causes of aphasia, I'd be more than happy to answer your questions about them. But today we're primarily going to focus on aphasia due to stroke. So in most people, language is located in the left hemisphere of the brain. And you see here 3 different MRIs. And you notice that there are some darker colored areas in each of these MRIs. Those are what we think of as the stroke lesion. The lesion is the site of damage following stroke. Now, as I said, usually it's in the left hemisphere when we're talking about aphasia. Now, you'll also notice in each of these MRIs that the lesions are not all alike. So even though they may be in the left hemisphere, sometimes they can be more toward the front of the brain. Sometimes they can be more posterior in the back of the brain. And you also notice that the sizes can vary. And the reason this is important to our discussion of aphasia is because the size and the location of lesion is a big contributor to the type of aphasia that someone may have, and also the level of severity of the aphasia. When we're talking about type of aphasia, we generally group types of aphasia into two major categories, and those are fluent versus non-fluent types of aphasia. Fluent aphasia, sometimes called receptive aphasia, sounds as if you are having a conversation with someone and that other person may sound like the conversation is flowing, but the words may not make a lot of sense. So you get the rhythm and the intonation of normal speech, almost as if you were listening to someone speaking a foreign language, but the words in your own language do not seem to make sense. For people with fluent aphasia, the comprehension of the language of others may also be impaired. So they may have difficulty understanding what you're saying. And importantly, they may not be able to recognize their own speech errors. So they may not demonstrate a lot of frustration, but they are making a substantive amount of errors in their speech. In the most severe cases of fluent aphasia, you may hear jargon or non-words. And in milder cases, you might hear somebody who appears to be talking in circles, sort of in a vague way. We call this circumlocution, when you're talking in circles. And you may say to yourself, well, hang on a second, I talk in circles all the time, or I know someone that talks in circles. But I want to reiterate that when we're talking about aphasia, we're not talking about things that lie within the normal continuum of differences in human communication. We're talking about something that affects the quality of life and one's abilities to perform daily activities. Now, in non-fluent or expressive aphasias, you do not hear conversation as if it's flowing. You hear verbalizations that are much more hesitant, with long pauses between words. And people with non-fluent aphasia will have difficulty naming objects, or may have difficulty with grammar and syntax. That means putting sentences together. People with non-fluent aphasia, unlike with fluent aphasia, will experience frustration when they're trying to get their words out. And that's because they know when they're making speech errors. The comprehension of those who have non-fluent aphasia tends to be relatively good. Although, admittedly, when we are testing patients who have non-fluent aphasia, as a clinician, we start to test at higher levels, and we do start to notice that even with the non-fluent aphasia, there can sometimes be some breakdowns in comprehension. In severe cases of non-fluent aphasia, there may only be one word present, a word that gets repeated over and over again, the same word. That's the one word that they can use. We call those stereotypies, when there are repetitions of words or phrases in aphasia. And in milder cases of non-fluent aphasia, someone may make sense, but might have many frequent episodes of verbal hesitations and have difficulty with word finding errors, what we call paraphasias, meaning words that are substituted for other words. So house for horse, for example, two words that sound alike, or horse for dog, two words that are semantically related. So now that I've told you a little bit about what to expect in fluent versus non-fluent aphasia, I'd actually like to show you some examples of what that actually sounds like. These are two real people who have aphasia. The first gentleman that you're going to be introduced to has a fluent type of aphasia. So remember, you're going to be hearing what sounds like conversational flow, but not a lot of sense making happening. And also not a lot of frustration, but clearly difficulty understanding what the other person is saying. Now, this video runs for 1.5 minutes, and I do want to run the whole thing because I think it's very interesting what happens at the end, and I will get back and talk to you about that after we've watched the video.
Hi, Byron. How are you?
I'm happy. Are you pretty? You look good.
What are you doing today?
We stayed with the water over here at the moment and talked with the people for them over there. They're diving for them at the moment. They'll save in the moment. He'll have water very soon for him. With luck for him.
So we're on a cruise and we're about to
We
get to
will
Juneau.
store it right here and they'll save their hands right there for them.
And what were we just doing with the iPad?
Right at the moment, they don't show a darn thing.
With the iPad that we were doing.
From-
Like here?
I'd like my change for me and change hands for me. It would happen. I would talk with Donna sometimes. We're out with them. Other people are working with them. I'm very happy with them.
Good.
This girl was very good and happy. And I play golf and hit other trees. We play out with the hands. We save a lot of hands on hold for us, other hands. I don't know what you get, but I talk with a lot of hand for him. Sometime. Am I talk of any more to saying?
All right. Thank you very much.
Thank you very much. I appreciate it, and I hope the world lasts for you.
Thank you. It's been a pleasure. Bye-bye.
Have a good day.
So you may have noticed that in spite of the fact that this gentleman was having so much difficulty communicating, at the very end, when he did something routine and automatic, have a good day, it came out perfectly fine. And that's one of the things about aphasia, is that sometimes automatic, overlearned words and phrases are not problematic. So interesting, right? So the next person who you're going to meet is someone who has non-fluent or expressive aphasia. So you're almost going to hear the opposite of what you heard with this gentleman. You're going to hear lots of verbal hesitations. Importantly, the next video showcases someone who is very young. And I think it's important to acknowledge that there are young people who do have stroke and do have aphasia. And fortunately, while it is rare, it does occur. This is an older video. So my understanding is the person in the video has recovered nicely. Actually, younger brains tend to do better in terms of aphasia recovery. But I think it does actually provide a very good reference for what non-fluent aphasia sounds like. And I'm going to play about a minute of this video for you.
Okay. So what's your name?
Scott. Oh, no. Sarah Scott.
That's right. And how old are you?
I can't.
Try.
I can't.
Oh. You're 19. 19.
Yeah.
Yeah. And what happened to you?
Stroke.
You had a stroke last year.
Yes.
And what happened? Can you remember what happened?
School and English class,
Okay.
and I book and I read it aloud, but I can't because stroke, and so I send and also it's the same as kind of thing as you know.
Pins and needles.
Yeah,
like pins
the
and
same, and also arm as well.
Leg. Leg.
Yeah.
Okay. So you noticed that she was struggling quite a bit to get the words out, but she was also trying to use other modalities of communication. She was trying to write. And of course, I can't see whether what she was writing was accurate, but you see that there's the perception of oneself as not being able to communicate, unlike with a more fluent aphasia. It also bears mentioning that these are two very broad categories of types of aphasia, and within each of those categories, there are several subtypes of aphasia. So not everybody who has one type or the other of aphasia is exactly alike. So it would be natural for you to ask yourself at this point, how does healing in aphasia actually occur? And there are really two very complex ways in which healing occurs in aphasia. And the first is there's something called spontaneous recovery. Spontaneous recovery occurs from the moment of stroke onset through the next 3 or 4 or sometimes a few more months. Within those first few months of stroke recovery, there is a lot of tumultuous activity occurring within the brain. And on the right, you actually see an image of somebody with a stroke lesion. And inside the center of that lesion is the core of the stroke, where most of the damage has occurred. But then right around the outside of that stroke lesion, you will see a lighter shaded area, and that's called the penumbra. And that's just a fancy way of saying that it's the area immediately surrounding the stroke lesion. During those first few months of stroke recovery, something very important happens. There's the restoration of blood flow to that penumbra, to that area around the stroke. But importantly, that area is not the only one that's impacted by the stroke. There are distant areas within the brain that, even though they're far removed from the area of the stroke, also experience a lot of tumultuous activity, a lot of upset and even damage during the stroke. And the process of having those distant areas affected by the area of the stroke is called diaskesis. What's important to know is that the reversal of that process occurs during the first 3 months or so following stroke. The reversal of those distant areas which were impacted by the stroke finally becoming less impacted, and the restoration of blood flow back to that immediate area. Something else that occurs during those first few months of stroke recovery is that there's activity in the opposite hemisphere of the brain from where the stroke occurred. Sometimes that's a positive thing, especially in cases of very large stroke lesions. Sometimes having activity in the other hemisphere is good. But sometimes that's not such a good thing. Sometimes we say that's maladaptive. We want most of the healing activity to occur in the area around the stroke lesion, particularly with smaller lesions. And you're going to hear me talk toward the end of the talk today a little bit about what we're doing in research to try to encourage some of that healing around the area of the stroke lesion. Now, you may have heard the term neuroplasticity in the news, or you might have read about it. It's a term that's sort of found its way into the popular culture recently. And all that really means is change within the brain. You will notice that at the bottom of your screen, there's another figure, and it's an image of 2 neurons that are communicating with each other. Those are 2 brain cells. And that space in between the 2 brain cells is called the synapse. During this first 3 or 4 months of stroke recovery, this spontaneous recovery period, there's a lot of strengthening or upregulation or weakening, downregulation of synaptic activity going on. And this increased activity helps to produce neuroplasticity, change in the brain. So there's a lot of disagreement in the literature about when during this spontaneous recovery period is the best time to start speech therapy for aphasia, and what intensity, what amount or dosage of speech therapy is the appropriate amount. But one thing with which the literature seems to be in agreement about is that early speech therapy does seem to take advantage of this neuroplasticity, this brain change in the acute phase or during this spontaneous recovery period. Now, the other way that healing or recovery takes place is through another complex process during the chronic phase of stroke or during functional recovery. The chronic phase of stroke occurs from approximately 6 months after the initiation of the stroke and continues essentially on an ongoing basis going forward. Now, during this functional recovery or chronic phase of stroke, recovery may be slower, but importantly, gains can still be made. Therapeutically speaking, the focus tends to be more on compensatory strategies. Now, new research is attempting to extend or even to replicate the previous spontaneous recovery period that I was speaking about to, in a sense, open the window a little bit wider on spontaneous recovery, extending the duration of it in order to maximize recovery. Nonetheless, at some point, one confronts chronic or functional recovery. During this period, there's something that doesn't get talked about enough, I think, and it's very important. And that is that people who are recovering with aphasia tend to go through a period of grieving and acceptance in this chronic phase. It's very important, actually, to pay some attention to this. I will tell you, subjectively speaking, as a clinician, those patients who are attended to during this period where their feelings of grieving and having to deal with, these are the deficits that I'm now left with, and I can still make gains, but it's going to be at a slower rate. The people who have support in dealing with that tend to do very well or better than people who do not get that kind of support during the chronic phase. For those reasons, group treatment for aphasia is often very useful during that chronic phase of recovery. So whatever support you can get during that phase is very welcome. Now, I've been talking quite a bit about what aphasia is and about how it's acquired, but it occurs to me that I've left something out, and that is, I'm assuming that we all know what language is, but what is a language disorder? What is language? I'd like to take a step back and just talk for a moment about what we mean when we talk about language, and frankly, how awesome it is. So we know that language is a means of communication, but think about this for a moment. Language can be spoken, but it can also be written, and it can be signed. And that's because language is expansive. It's extremely flexible, and it conveys meaning. So I can look at that picture of somebody playing a musical instrument on the screen there, and I can simply say that the musician plays, but I can also add information. I can say the musician plays a guitar. I can tell you where he's playing it. I can tell you when he's playing it, at midnight. I can even go into great detail describing why he's playing the guitar, and I can do it all in a grammatically correct, syntactically complex manner, adding more and more information. And that is a uniquely human form of communication, our ability to expand communication in this way. So language expresses itself through motor modalities, motor systems like the muscles of the face, the muscles of the mouth and respiratory system, and even the muscles of the hands. Language expresses itself through sensory systems like hearing and vision when we're making eye contact as we're speaking. That's actually part of pragmatic language. Our ability to make eye contact is an important part of language. And the visual system when we're reading language in the form of a book, for example. Language expresses itself through cognition. There are aspects of cognition like attention and memory that buttress or support language. Language expresses itself through social behaviors. So you may speak one way when you're being polite and another way when you're being informal. And of course, language expresses itself through culture. So someone who thinks of himself as particularly high class may speak in one way, and someone who thinks of themselves as being somehow culturally lower class may speak somewhat differently. And we know that language and culture are very much intertwined. So language is certainly complex, which leads to the question, how does all of that complexity find its way into the brain? Where in the brain is language? Well, it used to be years ago that I would say even as recently as 20 years ago, when we thought about language in the brain, we saw that first picture on the left, which shows you two circular areas. One is a little bit more in the front of the brain, that's Broca's area, and one is a little bit more posterior, that's Wernicke's area. And those two areas represented key language regions, Broca's area representing verbal communication, expression, and Wernicke's area representing comprehension of language. And these two areas were connected by a bundle of nerve fibers. Now, those things still remain true. But if you look at the image on the right, there has been such an advance in the last 20 years in neuroimaging when it comes to understanding language in the brain. This is much closer now to the picture that we have of language in the brain. And we realize that language is much more interconnected with other systems. So there still are areas that are responsible for speech production, and there still are areas that are specific to perceiving and understanding the comprehension of others. But we also know that they work in conjunction with each other much more than we ever suspected. And as a matter of fact, although there's no image for it on the screen here, the opposite hemisphere from where language usually occurs, in the left hemisphere in most people, the opposite hemisphere is also now implicated somewhat in supporting language processing. So much more complex. So I'd like to now turn to aphasia treatment. When researchers are looking for evidence in the literature about what treatment is especially effective for aphasia, one of the best sources to go to are what are called systematic reviews, where researchers are looking at multiple clinical trials over a particular period of time and trying to sort out which treatments seem to be most advantageous. Well, recent systematic reviews seem to indicate that more intensity in treatment, in other words, more frequent treatment, given over a longer duration of time, as opposed to patients receiving shorter treatment that's less intensive, that more intensive therapy seems to be beneficial. But interestingly, there hasn't been to date one particular behavioral aphasia therapy that has proven more successful than any other. So for the most part, when we are delivering aphasia therapy, it is individualized and customized treatment that's based on the individual patient's specific needs. There are no medications that are currently approved for aphasia treatment. Now, there are drugs that have been created to address other neurological disorders, which are involved in, you may remember I was talking about attention and memory, other kinds of cognitive issues. So those drugs that address those cognitive issues have been used in aphasia clinical trials for aphasia, and they have aimed to strengthen the neural activity in those networks. But these have only been found to be successful when coupled with speech therapy. Now, I wanted to insert this slide for a particular reason. This is a very busy slide, and that is because there are so many different types of behavioral aphasia therapies, and I wanted to illustrate that here. I will not be talking about all of these different aphasia therapies because it would certainly take hours, but I am going to tell you about one. And I'm going to focus just for a few moments on melodic intonation therapy. I'm not choosing that one because it's the best or because it's the most prominent, but because there's a lot of misunderstanding about what melodic intonation therapy is, and also because I think it would give you an interesting bird's eye view into what behavioral aphasia treatment might be like. So let's take a look at melodic intonation therapy. Developed in the 1970s by Nancy Helm Estabrooks and her colleagues, it has sort of withstood the test of time that many people still use this intervention. Honestly, it is primarily used with patients who are on the more severe side or who also have a motor speech disorder, specifically apraxia of speech. The idea behind it is that it's thought to recruit the right or the opposite hemisphere, particularly in patients who are having more severe difficulty even getting a word out. And the idea is that it uses rhythm and hand tapping and melody, which are more represented, it's thought, in the right hemisphere, in order to encourage verbalization. So here you see an image of some humming, right? And it's just two notes, one on top of the other. It's just two notes. And what the therapist does is she initially presents the humming and taps the patient's hand and gets the patient to hum along with her, and then gradually superimposes everyday words and phrases on top of that humming. What's for dinner? And it's thought that the melodic intonation acts as a conduit to help the patient get the words out. And there is visual material that's also provided in the form of picture cards during the therapy. The therapist gradually fades out, and then eventually the words are uttered without the melody. So the idea is to kind of lose the melody ultimately. Now, this is often confused with music therapy. And I want to really stress that this is not music therapy. They're two very different things. But the problem with melodic intonation therapy is really actually the problem with a lot of behavioral speech therapies for aphasia. And that is there's very low treatment fidelity. And what that means is there's no institute that you go to get certified in this particular therapy. There's no need to particularly follow the rules of how the therapy was originally outlined when it was first created. And so if you Google melodic intonation therapy online, you may see people with tambourines, you may see people with guitars, and that may represent music therapy, which is another talk for another time, but it is not melodic intonation therapy. Another example of therapies that we use in our clinical practice are computer-based apps. And these have actually gotten to be quite good in the last several years. Now, I've shown you an illustration of 3 of what I would say are the top makers of computer-based apps specifically for aphasia. But full disclosure, I do not receive any compensation from any of these companies. And there are many others, but these really are, I would have to say, the top 3. They do vary quite a bit, though, not only in terms of price. Some of them you're not charged anything for, and some of them are subscription-based service, for example. So there's a lot of difference in service delivery and what is provided. There are also differences in terms of the person's ability to use technology that's involved. So the bottom line is you really need to check with a speech language pathologist in terms of what computer-based apps might be right for you or your loved one. Another form of technology that we use quite a bit when we're working with patients who have aphasia is alternative and augmentative communication, or speech generating devices. And while these devices do speak on behalf of the patient, so therefore it's used mostly in more severe cases, there's been some very interesting research that's come out in the last couple of years that indicates that using speech generating devices actually may have a therapeutic effect. And this is because it's thought that patients are getting a lot of visual reinforcement and they're getting a lot of auditory reinforcement. And therefore that stimulation, that reinforcement, is helping patients who were formerly not able to verbalize very much to actually verbalize more as a result of using a speech generating device. So 2 different kinds of technology involved in aphasia rehabilitation. Now, this phrase is a phrase that I had on the wall of my very first job as a speech pathologist. One doesn't recover from aphasia, one recovers with aphasia. And for many, many years, I thought that this was a wonderful expression, not only of the realism that somebody needs to have when dealing with recovering from aphasia, that it does tend to be chronic, but also that one recovers with aphasia, that there is hope. So I thought this was a great way of expressing both the reality of aphasia recovery and also the hope of aphasia recovery. But I have to tell you that in the last few years, since I've been involved in research at Burke Neurological Institute, I have really been forced to question this statement. Does this have to be true? Does one never recover from aphasia? So I'm now going to turn my attention to that question and talk a little bit about aphasia research. Now, there are many types of aphasia research being conducted throughout the world, but arguably the most prominent area of research in aphasia recovery employs 2 types of non-invasive brain stimulation, and those include the 2 pictured here, transcranial magnetic stimulation and transcranial direct current stimulation, TMS and TDCS. Now, TMS, which you see on the left, sends a short, low frequency electrical pulse through a magnetic coil directly above a patient's head, just above the areas, in our case, associated with language. And the clinician uses an MRI to best determine the specific spot to provide stimulation. And these electrical impulses have the ability to increase or decrease activity in the brain cells. You may remember the image I showed a little bit earlier of that synapse between the brain cells. So that's what it's targeting there. And TDCS, on the other hand, which you see on the right side of your screen, also uses a very low current, but it's applied directly to the scalp via electrodes, usually for up to about 20 minutes at a time. Now you can see that TDCS is a lot more portable and it is more user-friendly, so that speech therapy can actually take place while the user is wearing it, which makes it a little bit more ideal in clinical settings. And together, both of these forms of non-invasive brain stimulation are thought to prime the brain to be more receptive to some of these behavioral speech therapies, much in the same way that you prime a wall before you paint it. Now, these devices are known to be safe. However, they're not yet approved for use outside of research settings because the precise location, the precise dosage, and the timing of delivery of these forms of treatment are still under debate. So here at BNI, Burke Neurological Institute, I was actually fortunate to be part of a 2016 study that compared TMS and TDCS, which Christine mentioned a little bit earlier this afternoon. It was done in conjunction with McGill University and the Max Planck Institute. And in this particular study, significant improvements were found in some aspects of language production in patients who had aphasia when TMS was applied to the hemisphere opposite the stroke lesion. However, there are other studies that show differing results, and more research needs to be done in this area so that we can more adequately understand its potential for aphasia recovery. Finally, I'd like to mention that we are continuing to do aphasia research at Burke Neurological Institute, and this is a study that I was fortunate enough to get involved in with Dr. Adam Buchwald at New York University, who initiated this clinical trial. And in this clinical trial, we are looking at a motor speech disorder called apraxia of speech in patients who have aphasia. And as with all studies, there's inclusion and exclusion criteria, meaning there's certain criteria you have to meet and certain criteria you should not meet when you are being screened to participate in a research study like this. If you are interested, or if you think you know of someone who might be appropriate for this clinical trial, I do believe that Christine will be posting information about our clinical research registry for this and for all of our clinical trials in the chat box to follow the talk. One thing I will tell you about this study, we were in the midst of doing it in March of 2020. And many of you no doubt will remember what else was going on in the world in March of 2020, and that is everything was shutting down because of COVID-19. And unfortunately, our study also closed temporarily due to COVID-19, but we do anticipate that it will be opening up, as are most of our other clinical trials gradually opening up. So if you have any questions about this, please feel free to reach out and look on our clinical trial registry. And with that, I want to thank all of you for being here. I want to thank the people at the Burke Neurological Institute who have supported my continued interest in research in speech and language, including the NeuroCures New York team and Dr. Raj Ratan and Tomoka Katago, Christina Fallow, Marissa Wunneman. I want to thank the outpatient speech department at the Burke Rehabilitation Hospital, where I also work treating patients. And I want to thank my colleague and mentor, Dr. Adam Buchwald at New York University. And with that, I would be very happy to take your questions. Thank you so much for your time.
Oh, thank you so much, Susan. That was a wonderful presentation. And I can tell you, I've learned so much about aphasia just by working with you on this presentation. And I think you really did do an amazing job of amplifying our mission, which is to continue to educate everyone out there about neurological diseases and disorders. So thank you so much. It was really a pleasure. So I'm just going to remind everybody that if you have any questions for Susan, we've got her really valuable time until about 1:30. So you can just put them in the chat window and I'll be reading them out to her. Also, just a reminder again about the patient registry for clinical trials at Burke Neurological Institute. In your chat window is the link, but you can also find it by going on the Burke Neurological Institute website. So I have a question for you, Susan. I'll get us started. So you were saying how there are two different types of brain stimulation and that one is more portable. I think one of the biggest challenges for folks who have aphasia, and I could be wrong, correct me, is oftentimes it's resulting from a stroke. And I would imagine in some of those cases there are mobility issues. What are your thoughts or your ideas, or what do you think the sort of future will be in a remote clinical trial to help those folks who don't have who either live far away or who don't necessarily mobility is an issue. I was just thinking you have this portable device that stimulates brain and potentially in conjunction with Zoom to be able to do the speech therapy. I mean, what are your thoughts on that? Where do you think we'll land?
Well, it's a great question. There certainly are clinical aphasia trials that are taking place through teletherapy, unquestionably. And I do think it's a great direction to go in, particularly for people who have difficulty with transportation, people who have mobility issues. Transcranial direct current stimulation is at present prohibitively expensive to send out to individual patients' homes. It's not impossible. I would just say that the cost is somewhat prohibitive. However, while I did focus on TDCS and TMS as being quite prominent in terms of aphasia research, it's not the only aphasia research that's being conducted. So I don't want to give the misimpression that that's all the different types of aphasia research that there are. But certainly there is telehealth, teletherapy, available not only through clinical trials, but just as a form of therapy. And my anticipation is that will continue and indeed be a wave of the future, sure. I hope that answers your question.
Yeah, no, absolutely. And I think it gives us all something to sort of think about. The other thing is I can tell from this audience and even from my own personal experience that a lot of us who are on this webinar today have a loved one or family member or a close friend who has experienced aphasia and the frustrations that come along with, therapies and the idea of repairing is really an exciting thought. And so just to kind of get us into the mindset, because obviously you study patients and you work with them, can you tell us a little bit about what is the biggest area of frustration? Like what, and I'm sure a lot of the folks who are on this meeting could also answer this question, but bring us into the minds of the person who actually is dealing with this issue.
I would say the biggest area of frustration, and I want to be cautious in how I respond here, because while I have treated patients with aphasia for over 20 years, I will never say that I know what it feels like to have aphasia. I do not. I am very empathetic towards people who have aphasia, and I understand a lot about aphasia and about treating aphasia, but I don't think that even after 20 years, I can fully understand what it feels like. I'm not sure how I ever could. But I do think, from my observation, the biggest frustration is in how therapy can be cut off by insurance. When therapy runs out, it's very frustrating. We were just speaking a short while ago about how the intensity of treatment has been shown to be more effective. If it's more intensive, it's more effective. If it goes on for a longer duration, it tends to be more effective. And yet the practicality of the healthcare system is such that patients don't always get intensive therapy for a long duration. And I think, honestly, if I were to pick one major frustration, that would probably be the thing I hear the most from patients. is that it's just hard to get that consistent intensive therapy that they really want and need.
Wonderful. Thank you.
Which is why I should add, which is why participating in clinical trials can often be a remedy for that, right? Because if you're having a lot of frustration in getting therapy, clinical trials, let's say you've completed your course of therapy, clinical trials are a wonderful way to continue to receive therapy even beyond the point where you're now cut off from getting further therapy from your insurance company or for whatever reason.
Absolutely. And we do have a lot of questions rolling in, so I'm going to try to get to everybody. Okay, next question. Can you discuss recovery in those who are bilingual, and if there are differences, and what are the punitive mechanisms for improvement?
So bilingual aphasia is its own specialty, and it is a fascinating field. In my clinical experience, working with patients who are bi or multilingual, all of the languages that the person may speak, whether 2 or 4 or 10 languages, however many languages, they're all impacted, no doubt, by aphasia. Because remember, it's the language system itself that is impaired, not just one particular language. But there are some researchers who feel that the first language that you ever learned will be the first language to come back and will come back the strongest. And there are other researchers who actually feel, well, it's whatever language you use most frequently. So even if, let's say, English was your very first language, but you went on to learn 2 or 3 other languages, that it's the language that you're using most often during your day-to-day experience that will be the one that will come back first. This is still an area of intense research, and there are a variety of opinions about that. Therapy is actually usually delivered in one language, which is the language that the person chooses. It's generally the language that they use in their day-to-day communication most often. But language therapy at home can be in whatever language they use at home. So people who are bilingual don't always use one consistent language, right? They may use one language at home with their family, another language at work. The thing to remember about aphasia is that it's the language system that's impaired. So all of the different languages will be impacted. The question of how much one is affected more than the other is still somewhat under debate.
Can I?
Wonderful. If you could you, Doreen, could you please type your question in the chat for me, because I need to try to get to them.
Yeah, it's
all.
hard. It's hard for writing. I have aphasia also.
Okay.
You can tell me, Doreen. I'm listening.
Go ahead.
That's very close to my heart because I was a polyglot. I speak 7 languages, and I can speak now only 3 languages fluently. But the other 4, I can communicate through music, and that's what I try to do in order to get ahead, because I was completely locked in. But my question, thank you for saying that about the languages, the variety languages, because not everybody knows or speaks about it either. Even for a speech therapist, they have no information about it. I went to Lehman University 4 years ago for a whole year doing intense therapy with 3 languages, trying to break the semantics.
Well, Doreen, if I may be permitted to interrupt you just in the interest of time, although I honestly would like to listen to you more, and perhaps we can touch base after the talk. I hope you can take a compliment, because I have to say to start with that you're doing a fantastic job communicating. And this is a great example of what people can achieve. I think my sense is that people who are polyglots and do have language spread more diffusely throughout the brain are at somewhat of an advantage. So I can certainly understand your frustration that all 7 languages are not necessarily back the way you would like them to be. I'm also a little bit jealous that you speak 6 more languages than I do. But I think that your question is actually a testament to how aphasia recovery can result in better functional how aphasia rehabilitation can result in better recovery, and that you're sticking with it, and that you're using music, and that you're using multimodal forms of communication. So I'd be happy, just in the interest of time, and I want to make sure everyone gets a chance to ask a question, I'd be happy to connect with you after the talk today. But I have to say, I hope you will continue to persevere, because you really have provided a great example for everybody here today. Thank you.
Thank you.
Doreen, I have your email address, so I will make sure that I connect you with Susan. So we're going to be going through the questions. So one of our participants has been losing his words over the past year, and he's wondering, would an MRI of the brain determine if it's aphasia or Alzheimer's?
So aphasia is a symptom of some forms of dementia, for sure. And you would really need to speak to a medical doctor who would order an MRI or a CAT scan in some cases to determine what's actually happening in the brain. Aphasia is not the thing that you really see in the brain. The thing you see in the brain is what causes aphasia. So for example, if somebody has Alzheimer's, that might be able to be visualized through a CAT scan. Or if somebody has a stroke, they'll be able to visualize it through an MRI. So the important thing to remember is that aphasia is the result of what you get because of a disorder or a trauma or a disease process that's going on in the brain. The short answer to your question is yes. You know, if you have concerns about having something of a progressive nature, you should consult with a doctor, and he or she may request that you have an MRI. I think that's a good direction to go in.
Thank you so much, Susan. And next, Barbara Kessler put in the chat, if anybody can see it and pull it up, the information for the National Aphasia Association. And basically, she's letting us all know that they provide a wide range of resources. And she also thought, Susan, it may be helpful if you could maybe, I know we're close to running out of time, it's 1:28, but maybe you could give some advice to caregivers and families on how better to support people with aphasia.
Well, thank you, Barbara, for that suggestion. I think that's a great idea. So, you know, I know that when I'm trying to communicate at home with my spouse, I'm sometimes talking to him with my head in the refrigerator, or I'm in the next room, or I'm shouting from somewhere else. These are things that we do all the time in the normal course of communication. But when you're speaking to someone with aphasia, it may be important to be very direct, to look at the person directly, make sure you have their attention and that they can see you. Sometimes visual cues, whether it's facial cues because of your emotions, or that they can really hear the intonation of your voice or read your lips, can be very helpful. The other thing is to make sure that you limit distractions, that you don't have a lot of noise going on in the background, which can be very disturbing for people who are trying to really focus in on what they're saying and on what you're trying to say. So minimizing distractions, maintaining eye contact, having lots of resources available, like have a whiteboard where you can try writing things down or drawing, or you know, have picture cards, photo albums, anything you can think of that might help with verbal communication. I think it's also an important part of therapy that is overlooked, that there should be some caregiver training. And it's important to make sure that the caregivers are a part of the therapeutic process and attend therapy sessions and speak to the speech pathologist. Such good questions you have here, Christine. I'm really impressed with these questions.
It's a great group, Susan. I mean, what can we say? It's a wonderful group of participants. So we actually have a question, and I know we're just about out of time, but we have a question from one of our colleagues, Susan. The patient,
now I'm in trouble.
The patient, the 19-year-old patient that was in the video that we saw with a great hesitation. Our colleague wants to know, do you know if TDCS was used? And if yes, did we see any improvement? I mean, obviously she's young and her neuroplasticity would be greater, would be the thought, but do you have any thoughts on that? Or
Well, the answer to the second part is yes, that the neuroplasticity would be greater. And I am not personally familiar with that individual, but I know that she has posted a lot of her journey of recovery on YouTube. And so she's somewhat, I don't want to say well known because that might be putting too much of a fine point on it, but she has posted a lot of her journey on the internet. And she did make fairly good recovery. And she is young, so that is definitely beneficial. Younger brains definitely do better in terms of recovery with aphasia, just because there is more neuroplasticity, and the recovery does tend to happen at a faster rate. Although not always, if you have a very large lesion, it can still do quite a bit of damage. I don't personally know whether that particular person received TDCS, but I do think that it would be not a bad way to go. I mean, when you're determining whether someone's appropriate for TDCS, you have to consider a lot of factors, and youth isn't the only thing. I mean, we would want to make sure nobody had metal anywhere in their bodies. If somebody has a shunt, for example, they may not qualify for TDCS. If they have a history of seizures, and that could happen in a young person or an older person, they may not qualify for TDCS. And some of the research is changing about some of those prohibitive factors with TDCS, but there's much to consider in determining whether or not someone's appropriate for it. If she didn't have any exclusion criteria that she met for it, I would think that it wouldn't be a bad thing to try, but it's difficult to say not knowing the patient, of course.
well, again, this has been such a great webinar, and I've learned so much, and I can tell from the faces of the people who are participating that I think they've learned a lot too. This was really helpful, Susan. And Doreen, I will follow up with you, so we will continue our conversation. Again, we want to thank you for taking the time to join us today. We understand that your time is valuable, and we're so grateful that you chose to spend the last hour with us. I want to thank you, Susan, again for a very impactful presentation, and also for your dedication to patients, families, and caregivers. A recording of this presentation will be available on the BNI website, but the link will be on the monthly newsletter. I wish you all safe and happy holidays, and we look forward to seeing you at our next BNI webinar. Have a wonderful weekend, everyone.
Thank you, everyone.